And now I would like to introduce our speaker, Dr. Jennifer Bray. Dr. Bray is a board certified orthopedic surgeon who specializes in pediatric orthopedics. Dr. Bray earned her medical degree from the University of Louisville School of Medicine. She completed an orthopedic surgery residency at Drexel University College of Medicine in Philadelphia and a fellowship in pediatric orthopedic surgery at the Campbell Clinic in Memphis, Tennessee. In addition to offering a full range of orthopedic care for children, Dr. Bray has special interests in pediatric sports injuries and trauma. Dr. Bray is on staff at Norton Children's Hospital and Norton Children's Medical Center, and she also has a clinical faculty appointment with the University of Louisville School of Medicine Department of Orthopedic Surgery. Thank you for joining us today, Dr. Bray.
Sorry, it took me a second to unmute. Welcome, thank you. Disclosure, she already put it up there. I don't have any financial incentive to talk about overuse injuries. Oh, there it goes. Most of the pictures I'll use in this talk are actually of my own children, which they are mostly okay with. My teenager's starting to get a little bit more upset, but they're old. So the pediatric athlete. So they're a lot younger than they used to be. It feels like, you know, kids didn't really play organized sports until high school or maybe middle school. I know at my middle school, we offered basketball and dance team, and those were the two activities that were school sanctioned. And now elementary schools have multiple teams and multiple sports, which overall I think is a very, very good trend. But they're a lot younger than they used to be. They compete a lot longer. They practice more hours. They train harder than they did, and they're still growing. So as we always say in pediatrics, children are not just little adults, and that includes even my big children. I had a patient in my office yesterday who was 6'5" and still growing and having growth plate issues. So it's always kind of one of those things where they're little adults, and sometimes they're actually just really tall children. So some of the different injuries that I see pretty commonly in my office, little league shoulder, Panner's disease, gymnast wrist, jumper's knee, Osgood-Schlatter and Syndergaard-Larsen-Johansson, those are kind of the twin syndromes. And then Seaver's disease. These are all growth plate injuries, you know, from top to bottom that we're going to see in kids. So again, kids start playing organized sports earlier and earlier. I have kids that are in gymnastics at age 2 or 3, which I actually am okay with because it's mostly learning about body mechanics and how to move around the environment, but also basketball leagues, soccer leagues, flag football, and they're practicing, they're competing multiple days a week, and these injuries really are pretty unique to growing bones most of the time. So when we talk about kids' bones, they have the same number of bones as an adult, but they're kind of separated into different pieces. So there's growth plates that are in between there, making those bones stretch and grow longer or grow tendon attachments. And those are actually really prone to injury. The cartilage is not nearly as strong. It can't resist force nearly as well as a bone can. And they really are about the weakest part of the immature skeleton. Growth plates and tendons and ligaments are all about the same if you look at their mechanical properties. One of the big issues that's really become a lot more in focus the last 10, 20 years is sports specialization, and especially earlier specialization. I was talking to a family the other day, and they said that their 8-year-old was told if they don't specialize in baseball within the year, they're never going to make it beyond that. And I just think 8 years old is pretty ridiculous, but that's kind of where the focus is for a lot of kids. So sports specialization is actually, it's kind of a 3-component thing. So it's focusing on one sport at the detriment of other sports and participating in that sport greater than 8 months a year. There are certain sports that are a lot more prone to this than others. Gymnastics and baseball are kind of the 2 most common ones that I see. And what we know from this is that they have about a 2.25 times higher risk of getting injured than kids who just participate in recreational sports. This is just a little kind of table showing the injury risk. And the more highly specialized you are, the much higher risk of injury that you have, the risk of serious overuse injuries. But nicely enough, they are at lower risk of acute injuries. They do learn how to move their bodies a little bit better in that sport. The exception to that being soccer because of a lot of damage to the knees in soccer players. So just kind of an interesting thing, like the more specialized you are, the more likely these problems are to happen to you. When I was in training in Memphis, Jim Beatty always called it the John Deere dad hat syndrome, where you would have a lot of these dads come in, usually with their teenage sons, and dad is 1000% more concerned with getting little Jimmy back on the football field than little Jimmy seems to be. So there seems to be a lot of overbearing parenting when it comes to overuse injuries. My little caveat to that is I had a patient come in January one year wearing his baseball uniform, and his dad was wearing the same uniform in January. Like, that was just a huge red flag to me, that this is a parent who is much, much, much too concerned with their 10-year-old's baseball career. I will pick on moms a little bit too. I used to call this coach purse mom, but I have to upgrade and get with the times. This is the Lululemon crossbody mom nowadays, where typically the same as the John Deere hat dad, but usually for their daughters, usually dance team, cheerleading, and gymnastics tend to be the three biggest culprits for this problem. All right, so just kind of starting with body systems, back pain. Back pain is actually really, really common in adolescent athletes, about a 1-year prevalence of about 40%, especially in not just collision athletes, but any athlete requiring a lot of flexion and extension of the spine. There are very specific hyperextension injuries in hyperextension athletes, mostly gymnasts, football linemen, especially offensive and defensive linemen, from how they block and extend their spine, and volleyball players as well. This picture actually is of my son. This is him serving. So he's pretty far off the ground, and you can see how far back his spine is extended to the lumbar spine. We didn't think much of this. He's been playing volleyball along with other sports for a couple of years. We got him a backyard volleyball net this summer. We thought it'd be fun for him to go out and practice, and he would play 3-4 hours a day, pretty much since the weather got warm, and went off the diving board about 3 weeks ago. Kind of landed wrong, went to practice that night and can't hit. And it's been about 3 weeks where he cannot extend his spine right now. So me being his mom, what do? I get x-rays and an MRI. And what I found on that is that he actually does have a stress fracture in his spine. So he is actually shut down from volleyball currently. So the left side of his spine, right there where the vertebral body goes into what's called the pars and the pedicle, has a lot of inflammation. He's getting better. He's otherwise fine, but this is, I am apparently a Lululemon mom now. I do have a bag, actually. All right, so upper extremity injuries. Again, mostly going to be seen in athletes who use their arms more, baseball players, gymnasts, and the names of these processes reflect that. So little leaguer shoulder, little leaguer's elbow, Panner's disease, osteochondritis dissecans, and gymnast wrists. And I'll get into each one of these. A lot of these injuries have a very seasonal presentation. Little league shoulder, little league elbow tends to be early in the baseball season, so kind of February, March-ish type of time frame. So these are kids who usually travel ball. They take a little bit of time off over the winter months, but then they start picking it up again. Or they'll start working with their pitching coach or their position coach starting in about January, getting ready for like the March and April tournaments. So about every year in February, I have kind of a whole boatload of kids come in with new onset shoulder and elbow pain. Little league shoulder tends to be a little bit towards the older category, some more the 13 to 15-year-olds, whereas little leaguer elbow tends to be more like 8 to 12-year-olds. And little leaguer shoulder actually is a stress injury of the proximal humeral growth plate, so the physis at the top of the humerus. If you look at the mechanical breakdown, and they've done all kinds of movement studies on pitchers, the stresses at the top of the humerus are within the like several hundred Newton meters per second of acceleration right on that growth plate. And it does cause a lot of stress. That's just cartilage there. It's not nearly as hard as the bone. And the bone and the muscles and the tendons around that joint also aren't really strong enough to handle that stress as well. So it is excessive throwing. About 10, 15 years ago, the big focus on pediatric pitchers was to avoid junk pitches, so curveballs, off-speed pitches, because that was what the feeling was that would mess up your arm. And actually, the studies since then have just shown it's just throwing. It's plain old simple too much throwing, and especially the harder that you throw. So fastballs are actually a little bit more dangerous, and this can affect pitchers, catchers, outfielders. I've seen it in pretty much every position player at this point. The pain usually starts when the patient is throwing, and then it resolves once they stop their session. As it gets worse, it actually starts to hurt even when they're going to sleep and then waking up the next morning. So here's an example. This is I think a 12-year-old boy came into clinic a few years ago, complaining of right shoulder pain. Got an x-ray. It's not particularly interesting if you just kind of look at this shoulder. That arrow is pointing at the proximal humeral growth plate right there. Again, not particularly scary looking until you look at his left shoulder. And that growth plate is about twice the size of the normal unaffected left shoulder. So this is a very, very nice example of what a little league shoulder can do to that proximal humeral growth plate. The treatment process for this, number one, this is the one that gets people upset, is you got to stop throwing. There is no way around it. A lot of these kids will also hurt when they are batting and when they are fielding. So you kind of have to shut down baseball altogether. Every once in a while, I'll get a kid whose symptoms have only been going on for a few days and they don't hurt with those other activities. I'm usually okay with them pinch hitting only. Um, we always get them into physical therapy. We have some physical therapists around town that are very, very good about implementing progressive throwing programs with these athletes, making sure they're working on the stretching, working on the strengthening, not just of their arm, but also their core and legs. A lot of the throwing strength actually comes from below the neck, and some people don't seem to realize that. We also typically would put them on a short course of scheduled anti-inflammatories. If I have a kid that I can't trust, I will also throw them in a sling, almost just to keep them immobilized for a little while to keep them from continuing to use it. Little League elbow, again, pretty similar patient population with overhead athletes, but tend to be a little bit younger than the Little League shoulder. This is microtrauma to the apophysis. So the apophysis is a part of a long bone where a tendon will later attach. It creates the bumps of the bone. Mostly medial epicondyle, sometimes the trochlea. Those are the two growth plates at the medial part of the distal humerus. Treatment about the same as the shoulder, cessation of throwing. Every once in a while, a kid will come in who was having some pain, and over time it got worse and worse, and then they throw and feel a pop. And sometimes you'll get an x-ray and you'll see a little separation of that growth plate. Most of the time you do not, but I will cast them and treat them as an acute stress fracture if that does happen. Another set of examples. So this is a much younger kid. So this is an 8-year-old's elbow. Not super duper obvious findings, but again, very subtle when you compare that to the contralateral elbow. There's a lot of white sclerosis kind of right next to the gap in between the medial epicondyle itself and then the rest of the humerus. So this is kind of white, this is kind of raggedy looking. And a lot of times the medial epicondyle itself will actually turn very white from the stress. Whereas if you look at the other one, it's still nice and gray, nice smooth border at the end of the humerus on the unaffected side. An acute fracture, this piece will sometimes end up over here. So again, something that needs to be casted, not typically a surgical problem. Panner's disease, pretty rare, but this is kind of an overuse syndrome of the capitellum, which is the lateral portion of the elbow right here. It's similar to Legg-Calvé-Perthes disease or Kohler's disease in the foot, where it's an idiopathic avascular necrosis. We don't know what causes this. We see this more in baseball players. And the blood supply, the artery to that bone just kind of gets kinked off for a little while. We don't know what causes it. It does come back. It always comes back eventually. The key is making sure the patient doesn't get flexion contractures and deformity while that blood flow is reestablishing. Almost always kids under 10, they kind of have vague elbow pain. They will sometimes lose the ability to fully extend that elbow. Usually no history of injury, maybe some puffiness over the outside of the elbow, but the big thing is the flexion contracture. Treatment for this, really just rest. Sometimes I often will do physical therapy for these just to make sure that they're building the strength and getting the range of motion back in that elbow. Very, very rarely do I ever cast these because I don't want them to lose additional motion. And remodeling is really the key. The bone will come back. It's just making sure the bone stays nice and rounded and healthy when it does. OCD of the elbow. So OCD stands for osteochondritis dissecans. This is another avascular necrosis type syndrome where the blood supply to that part of the elbow is lost. The danger of this is if that bone gets damaged, the cartilage that lays over top of it can actually fall off. I always think of it as like the bone is the glue that holds the cartilage to the elbow, and without that, the cartilage can detach. So this is older children, almost always overhead athletes, baseball players, gymnasts. I did have one rifle shooter who got this as well. The capitellum, which is the lateral apophysis of the distal humerus, is fused by this age typically. OCD is a much trickier problem to treat. This requires a lot of cessation of activities, and it lasts a lot longer than Panners. Some of these times we actually do take these to surgery. This is a kid's elbow. This is the capitellum right here. This should be very smooth. It should look like a little eggshell kind of sticking up out of the bottom of the humerus right here. And instead it's just a kind of a crater of this gray dead cartilage. So what we did with him is we took a plug of cartilage out of his knee in an area that doesn't need as much cartilage and basically swapped those out. So now he's got a nice round capitellum again, just kind of a cool surgery. Gymnast wrist, not super duper common. The gymnasts do tend to train more hours than about any athlete I've ever taken care of. They will train 20 to 30 hours per week. In case you were wondering, the NCAA Division I limit for training is 20 hours per week. So these are 12 to 15-year-old, usually girls, training more than Division I athletes will. That's a lot of force on their hands. Anything where they're upside down and using their hands to bear weight is going to be involved in this. On X-ray, what you'll typically see is, again, widening of the distal radial physis. So if you want to know what the physis would look like, you can look at the thumb physis right here, which looks nice and thin. The ulna doesn't look too affected, but that ulna is very wide, very sclerotic, and very irregular looking at the wrist. A lot of times this is also bilateral. It's usually kind of a diffuse pain that they'll notice when they're doing vault or floor and moving around on their hands. Again, starts to hurt with rest after a certain period of time. Treatment for this, you almost always have to cast a gymnast. They are very, very dedicated athletes. They do not like to be out of the gym. So I will put them in a cast for a few weeks and still send them to the gym because they can't stay out. They will do strength. They will do sit-ups for 3 hours if you let them. So I'm usually okay with that. I want them to keep up their strength and keep up their cardio while they're resting that hand. Typically, we'll keep them in the cast for 3 weeks of physical therapy to regain their motion, check an x-ray, make sure they're pain-free, and then gradually let them go back to activities. So lower extremity problems, so hip, knee, and ankle. All right, so these are a lot more common than the upper extremity syndromes just because all athletes use their legs. So snapping hip syndrome, kind of a rare one, typically is in that teenage population right around skeletal maturity. More common in females than males. Part of that is female anatomy. We do have a higher hip angle than men. So our hip takes off at a steeper angle, and the muscles that sit over top of that have a higher angle to rub against. Patients will usually describe kind of a popping sensation. They'll feel like the hip is actually dislocating certain times because of how much the muscle will jump when it finally snaps over. Again, usually towards the end of skeletal maturity, sometimes associated with activities. On exam, they will often have very tight iliotibial band and tensor fascial lata muscles right near the gluteus medius. So the abductors tend to be very tight. They can also have groin pain if they're having internal snapping hip. Every once in a while, you get lucky and the patient can reproduce it on the table, and then you can just kind of point to, hey, that's your muscle popping over your femur that's causing that. Radiographs, again, mostly to rule out other pathology, but snapping hip itself will not cause x-ray changes. Just a little diagram of internal snapping hip. This is caused by the iliopsoas tendon, which comes out of the back of the lumbar spine and the iliac wing, runs over the femoral head, and then attaches to the lesser trochanter of the femur. And when this hip is externally rotating, the neck of the femur will actually pop under this tendon, or the tendon will pop over the iliopectineal ridge that sits just medial to that. And again, that muscle is getting really tight, and then all of a sudden pops, it'll feel like the hip is popping out. External snapping hip, pretty similar, except this time it's the iliotibial band, which runs down the side of the leg, comes from the tensor fascial lata muscle on gluteus maximus, popping over the kind of the bony prominence right at the proximal femur right there. That one tends to be a little less violent, but actually is really interesting to see on physical exam. Treatment for this, most of the time we do not need to do surgery for this. Rest from activities, especially activities that are causing it pain. Ice, I will do sometimes. Sometimes heat actually helps us better. Anti-inflammatories for this. And then really physical therapy, stretching out the gluteus medius, stretching out the tensor fasciae lata and the iliotibial band, trying to just make that tendon a little less tight so it's not snapping so forcefully. You can do corticosteroid injections, and surgery is very, very, very limited applications, basically lengthening the tendon. In 15 years, I've never had anybody need that. Hip stress fracture is pretty rare. You're going to see this in your running populations, or your track athletes, cross country runners, and military recruits. That's where a lot of our studies come from, is actually the Army. This is known as a compression-sided fracture. This is an MRI showing a black, actually called the dreaded black line, at the bottom of the humeral neck right here, and like the edema around that neck on the inside of the femur. This is called compression-sided. The treatment for this type of stress fracture is crutch use. You have to get these kids off of their leg, or this will cause itself a full fracture. Very rarely, not very rarely, rarely these do need surgery, because even with that, the fracture will not heal itself. Check vitamin D levels, check calcium levels, make sure they're getting a good nutrition, and screen for red S, which is the low nutrition and low caloric intake sometimes seen in athletes for weight loss. Tension-sided fractures. So that is the line up on the proximal side of the femoral neck. These are a surgical indication 100% of the time. They're pretty rare in kids, but if you see that line, that patient needs to be referred to surgery, because this is a fracture waiting to happen. All right, so different knee problems. Again, there's my teenager again. He's in a lot of these. So osteochondritis dissecans, Osgood, jumper's knee, SLJ, and patellofemoral pain. And this is my son playing volleyball about 2 years ago. Really bad Osgood Schlatter apophysitis when he was about 12 and 13. Couldn't play without his bands for a couple of years. So osteochondritis dissecans of the knee. We don't really know what causes this and why it happens in some kids as opposed to others, and we don't really know the incidence. I have diagnosed this a few times in video game kids who are coming in for some other problem, and I just happen to notice that they have it on x-ray. In active kids, what it typically causes is kind of pain, recurrent effusions, and they'll sometimes get like a popping or a snapping sensation. So mechanical signs that they'll have when they're playing sports and running. They will usually hurt if you press kind of right into the knee, right on that medial side, just under the patella. There is a test for this known as the Wilson test, where you bring the knee up to about 90 degrees of flexion, internally rotate the foot and extend it, and that'll kind of press the tibia into that and recreate their pain. And recurrent effusions are pretty common. These are typically very, very late signs though. Pain is usually the only thing you're going to get at first. The most common location for this is the lateral edge of the medial femoral condyle. So almost always, this is the lateral side of the knee. This is medial, and you'll see this little spot kind of sitting right on the inside of the knee. These can occur laterally. They can occur on the patella and on the proximal part of the femur, known as the trochlea. Those are a lot less rare, and those also don't heal as well. I get an MRI on all of these to see kind of how big the lesion is, to stage it and look for any signs of instability. An unstable OCD will require surgery. For most pediatric athletes with open growth plates, these will heal on their own. The number we used to quote was in the 80 to 90% range, but newer research has shown that's really only about 60 to 70%, even if you keep them off of it, on crutches, out of sports. Some people will use something called an offloader brace to try to push the weight onto the lateral side of the knee. The outcomes are still not as good as we thought they were. Surgical treatment usually consists of some type of drilling. These little white lines are supposed to represent a drill coming from outside the knee and into that fragment to try to stimulate bleeding there. I typically do arthroscopic, which is where I look from the inside part of the knee and drill the other direction. This is an example of a patient of mine from several years ago. Again, OCD at the medial femoral condyle. Once we got in there and kind of looked at it, this piece was bulging out quite a bit. So I put, this is called a compression screw. So this is, it looks huge. It's pretty small. It's about a 2mm screw that actually goes into this to kind of push that piece back into place, and then drill holes around it to try to stimulate that bony ingrowth from bleeding. Arthroscopic treatment is typically the treatment of choice at this point. If the lesion looks pretty stable, you can just drill. If it looks like that piece is beginning to fall, again, the bone is the glue that holds the cartilage on. So if that bone is really sick and the cartilage is loose, you may have to kind of push it back up there and tack it. It almost looks like drywall anchors. And sometimes the lesion is totally dead, and all you can do is remove it and try to find something to replace it with. Just a quick example. This is a 14-year-old girl, so still skeletally mature growth plates, but a little OCD right here. And it kind of disappeared from the office for a couple years, came back. Lesion was completely unchanged. MRIs done at that point showed this lesion, and you can see this white line kind of coming up over the base of the lesion with a little bit of edema and white spots behind it. This piece has kind of walled itself off from the rest of the femur, and the ability for that to heal itself is pretty low, and just a picture of it on a T1 image. Patellofemoral pain. This is the most common overuse syndrome that I see by about 100 miles. Almost always it's active young adolescent girls, and often at the start of a athletic season. So this is a girl who maybe hasn't kind of played any sports or done much conditioning for a few months. Field hockey season starts, they're getting out there, they're running 4 or 5 days a week, and after a few weeks, their knees start to really hurt. Typically pain with going up and down stairs, with squatting, and then prolonged sitting and going to stand. This is also sometimes called movie theater disease because they'll sit in the movie and then go to stand up and kind of grab both of their knees. On examination, usually not much to see, just kind of vague anterior pain. I have had some patients actually get pretty good effusions just from the irritation under the patella. If you have them sitting up and ask them to extend their knee, you'll sometimes see their patella come up and then kind of hook off to the side at the end. That's known as the J sign and a sign of patellar maltracking. And I also watch them walk. Especially in girls, we tend to have, again, wider hips and what's called a higher Q angle, which is where our knees look a little bit more knock-kneed, and that can also pull the patella towards the outside and cause it to rub more. Another name for this, also called marching band disease. About every July when marching band camp starts, and I have girls who are not usually at baseline athletes, and then they're asked to stand in the heat for 7 to 8 hours a day, and all of a sudden their knees really hurt. So you'll see kind of an uptick in this in the middle of summer as well. The treatment for this is rest, but not inactivity. You don't want them to totally shut it down, because that's actually going to decrease the strength in their quadriceps and their gluteus medius. And those are the things you actually really need to strengthen. So I usually just tell you to cut back, do cross training, do swimming, stationary bike, things like that to kind of keep it moving. Ice after activities can help a lot. I am a huge fan of scheduled anti-inflammatories for this problem. And I would put every single girl and boy that I see with this into physical therapy, again, working on those gait mechanics, working on strengthening the quad, strengthening the glutes, and really just kind of taking that burden off of the patella itself. Bracing, I don't do anything more than a knee sleeve for compression, but it does help a lot of people. Patella instability, subluxation, and dislocations. So pretty similar population. Again, it tends to be adolescent girls, higher flexibility, higher ligamentous laxity, and higher Q angles at the knee. And what a lot of girls will feel is just, again, that feeling of they kind of turn around and it feels like their kneecap's trying to pop out to the side. Also associated with things like femoral anteversion. So they naturally rotate their hips in, which naturally rotates the patellas laterally. So got a bit of pain with this. For a first-time dislocation, treatment is usually physical therapy, some sort of patellar stabilizing brace, and cessation of competitive sports, but again, working on getting strength back with physical therapy. For repeated dislocations and repeated instability, you can try rest if you have kind of a patient that's not super high demand or really wants to avoid surgery. But if you have a patient who's had multiple dislocations, is having pain, or someone who dislocates and actually fractures either the patella or femur, that is a surgical indication, both for fixing the fracture as well as reconstructing acutely. Oh, sorry, I thought I had one more slide. Sorry, this is this slide right here. This is the reconstruction that we typically use for patella instability. This is known as an MPFL, medial patellofemoral ligament, and it kind of looks like a 3-point harness like you would see on a seatbelt. And that's what I tell patients. The patella can still go up and down just fine. It just can't pop out to the side anymore. So really, really good surgery for this. Discoid meniscus, not really an overuse injury. This is a congenital problem, actually. But it presents more like an overuse injury. You have a kid who, when they're outside playing, after a little while, their knee starts to hurt. It'll get a little puffy, and they'll have popping or catching. Like they go to extend their knee, and you'll see a little clunk on the outside part of the joint line. So again, this is congenital, but it doesn't usually cause problems. Kind of the typical presentation for a kid under 10 is mechanical symptoms. You'll see them kind of swing their leg out when they walk as well. In teenagers, it presents more like a torn meniscus. They're going up a hill, they make a pivot playing sports, feel a pop, and then all of a sudden their knee swells up, and it acts very, very much like a torn meniscus. The treatment for these, if they're symptomatic, I've had discoids present in 3-year-olds. I try to get them to 6 or 7 before doing surgery, if they can tolerate it for a few years, just because their knees are so small, it's hard to operate on. Treatment usually consists of taking that center portion and cutting it out. That's called saucerization. But a lot of these also will be missing some of the ligaments that connect the meniscus to the tibia, and I have to reconstruct those to stabilize the meniscus as well. Kind of a blurry picture from an old article. A normal meniscus should have very organized sheets of collagen running through it, whereas a discoid kind of looks like an abstract painting. You'll get these big degenerative blobs of kind of fibrous tissue throughout it. So the meniscus itself, again, congenital problem, the meniscus itself is very unhealthy, which leads to a lot of these problems. This was a 6-year-old girl. This is a very, very long time ago. This girl's in nursing school now. These are coronal images of the knee. These are sagittal images of her right knee. This cute little triangle right there is the medial meniscus sitting in between the femur and the tibia. And if you look at her lateral meniscus, it looks like a little baby whale sitting that somebody had shoved into her joint. This is a gigantic discoid meniscus. Other things that I can see is that I don't see those ligaments in the back. So you can see kind of the cyst formation where the meniscus isn't attached where it should be. Kind of an interesting case. And about 6 months later, she came back and look at that. She's got it on the other side as well. So normal medial meniscus, little baby whale sitting on the outside. And ended up having surgery on both. The rate of bilaterality is somewhere around 1 in 3. It's kind of a rare presentation, but more common in Asian populations, especially Japanese. These are some of her arthroscopic images. This is her ACL sitting right here. A normal meniscus should look like a little skinny wedge, and instead it looks like somebody stuck an entire body pillow up into her knee right here. These are just a couple of views of it. If I pull this piece back, what you can see is that it's actually not attached to the rest of the meniscus. So this is her tibia down here, and this is that meniscus that I've pulled forward. So the treatment is cut out kind of all this deranged tissue and then try to repair what you have left at the back. So there's tibia, there's meniscus, here's femur up here, just trying to make it look like a normal meniscus, even though it isn't. So the growth centers of the knee. So again, kind of back to these growth plate problems. You've got a distal femoral physis, proximal tibia physis, tibial tubercle physis, this little tongue that always sticks down that kind of panics parents a lot of times, and the growth plate at the distal pole of the patella. And I always kind of think of it when I'm teaching my residents or my pediatric residents that come through, the front of the knee is kind of like a stop sign. Patients are either going to point at the red, the yellow, or the green, and that will tell you exactly which process is going on. So the red is the distal pole of the patella. That's Syndergaard-Johansson syndrome. Oops, spelled Johansson wrong. Yellow is patellar tendonitis, which is the tendon itself. Green is Osgood-Schlatter apophysitis, and that's the tibial tubercle causing pain. So Osgood-Schlatter apophysitis, originally described well over 100 years ago, and just in adolescent boys, but it absolutely occurs in girls as well. Usually kind of, again, kind of a vague onset, not usually any sort of injury that predisposes this. It just kind of shows up one day, and it's often bilateral. You can get quite a bit of swelling. They're usually very acutely tender right there. They can't kneel on their knee, and if somebody kind of hits them in their knee, it causes a lot of pain. Usually pain during and after activities. Usually if they've been kind of at rest for a while, won't bother them so much. By definition, this is a growing pain. This is a growth plate problem. So it will resolve with age, but sometimes that bump is permanent. As Osgood-Schlatter progresses, sometimes little bits of that growth plate will kind of pull off and then ossify, and it'll leave that permanent bump behind. My dad is 75 years old and still has his perfect Osgood-Schlatter bumps from 60 years ago. Treatment for this, reassurance, this does not mean you have bad knees. This isn't arthritis. This doesn't mean you can't play sports. It really is just pain. The typical treatment, ice, stretching, making sure that the extensor mechanism, the quadriceps, the patellar tendon is as loose as it can be, so you're not pulling extra force on that tibial tubercle. This is called a Chopat strap, or a patellar tendon strap. Basically kind of sits over the patellar tendon to kind of pull some of that, pull a little bit of the tension off. I will usually do scheduled insets for this, and if they're really weak or really tight, I will put them in physical therapy as well. Very rarely do I ever do casting. Some kids will kind of present with kind of an acute Osgood Schlatter where they were playing and maybe landed on it, and now have pain there, but x-rays are normal, but they still hurt on the tubercle, and I will treat them more like a tubercle fracture. It probably truly is Osgood Schlatter though. Does it cause the big tibiotubercle fractures? That is super debatable, and we don't really know the answer to that yet. Syndig-Larsen-Johansson syndrome. This is from the growth plate at the bottom of the patella. Sometimes it'll cause this little hook at the bottom of the patella. A lot of times you'll just see a kind of a white line kind of parallel to the anterior surface of the patella, and that can also represent that same growth plate. This is another traction injury. Treatment is exactly the same as Osgood Schlatter. Jumper's knee. This is also known as patellar tendonitis or patellar tendinosis, and it's kind of a degeneration and inflammation of the patellar tendon, usually pretty close to the patella. Similar populations with regards to sports, basketball players, volleyball players, jumping athletes, but usually they are skeletally mature. Again, the ligaments tend to be stronger than the growth plates, so they will usually be affected first. But so once those growth plates are closed, that pain goes right into the patellar tendon. Foot and ankle problems, sprains, strains, kind of everything in between, as well as some congenital issues. Tarsal coalition, pretty common cause of foot pain, especially in the 8 to 10-year-old age group. This is a congenital problem, but usually the foot is so flexible in young kids, they won't notice this until that bone starts to actually ossify, and then the two ends really connect to each other. So this is a very nice example of a calcaneonavicular coalition right on the outside of the foot. The problem with this is it alters the mechanics of the foot. So when they're playing sports and they go to make a turn, they're much more likely to sprain because their ankle is just a little extra stiff than it should be. This occurs in about 5% of the population, so not super common. 5% of the population, but maybe 10% of them will ever have symptoms. Treatment is rest, reassurance, sometimes a short period of casting. For those that continue to hurt or continue to have ankle sprains, you can go in and just basically cut that bridge of bone out of the foot. Accessory navicular, moderately common congenital problem with the foot. This is the navicular bone sitting right here, kind of on the inside part of the foot. Geist type 1 is just this little tiny dot at the bottom of the navicular, but it sticks out medially. A type 2 is a bigger ossicle that sticks out medially, and a type 3 is actually fused, but a very, very long nose sitting on the inside of that navicular. The problem with that is this is the posterior tibial tendon, which runs right across that navicular. So if you've got extra bone right here, this is going to rub up against that like a rope over a corner, and it's eventually going to fray and really start to cause pain. So when you see these patients, you'll see it looks like a big knuckle of bone kind of sticking out, and then the tendon will hurt all the way back to the ankle. Treatment for this usually starts with casting and physical therapy, and you can excise that extra bone. You have to cut the tendon out of the way first, excise that bone, and then repair the tendon back where it belongs. Pretty good outcomes. Ankle instability kind of has two kind of flavors to it. More common in females. Again, anybody who has ligamentous laxity at baseline. So there's recurrent ankle sprains where the actual ankle ligaments are much looser than normal, so the ankle itself moves more. Another version of this is where the peroneal tendons, which run down along the outside of the ankle, those will actually pop in and out over top of the fibula and cause popping. Symptoms are pretty vague. Usually it just kind of hurts if they've been walking for a long time or running for a long time. On physical exam, again, have them stand on their toes and see if those peroneal tendons are popping over the outside of the fibula. And then when they're seated, just grab their heel in one hand and pull forward while holding the tibia. And what you'll often see is that instead of the ankle just moving just a tiny bit, it'll move a whole bunch and kind of recreate their pain. So that's an unstable ankle. Usually treatment, sometimes you can do a brief immobilization if they've recently had a sprain or an injury. Physical therapy kind of depends on the type of ankle instability you have. A lot of balance and proprioceptive work. So this is a balance board doing ankle therapy right here. Basically just making sure that those ligaments and tendons are working as good as they can to decrease that risk of something happening out in the field. Seaver apophysitis, so similar to Cindy Larson and Osgood Schlatter apophysitis. This one's in the heel. This one tends to be younger than the knee apophysitis. My two older kids both had this from cross country when they were around 8 to 10. This is an inflammation of the calcaneal apophysis. So if you look at the back of the calcaneus, you'll see this little white semicircle, and that's actually where the growth plate comes from. That's the Achilles pulling up on it. So these are kids who do a lot of running, and especially in cleats. Football players, soccer players, cross-country runners, cleats have about 0.01 inches of padding in them. And so pounding on that hard surface or on hard dirt over and over again just kind of pushes up on that growth plate and recreates the pain. If you ask them if it hurts more to walk barefoot or in squishy tennis shoes, they'll almost always tell you squishy tennis shoes feel much better. Treat like all the others, lots of stretching, especially of the Achilles. If they have Achilles contractures, I'll put them in PT to help them with that stretching. Sometimes for really acute pain or pain that isn't getting better, a short period of casting with the foot in as much neutral as possible to keep the Achilles on stretch can help for a short period of time. So again, treatment, ice, scheduled NSAIDs, heel cord stretches, heel cups. So something to go inside the shoe to make them a little squishier than your normal cleat, and time. Again, this will go away as that growth plate fuses, but it hurts for a while. Iceland's apophysitis. So again, a cousin to the other apophysitis. This is the base of the fifth metatarsal. This is always a confusing find for radiologists. This is a totally normal x-ray. You have to base this on symptoms. So if it's been hurting for 3 months, that's Iceland's. If they trip down the stairs and it hurts, this is a fracture. And that's the only way to tell, is based on history. So overuse, again, this is where the peroneus brevis tendon attaches, as well as some of the plantar fascia. So running and pounding on that foot will keep pulling and pulling on that little growth plate until it starts to hurt. This growth plate typically fuses in the early adolescent period and then is gone and then is part of the fifth metatarsal. All right, so kids are very prone to overuse injuries, especially those who play, who are specialized in one sport. The pathology and the treatments are really different. You've got to treat the growth plate and you've got to treat the kid. And yeah, parents will kind of give you the stink eye, and I'm kind of doing that to myself because I'm not letting my son play at volleyball nationals next week, but I have to be the doctor in this situation. And that's all I have. Thank you.
All right, thanks, Dr. Bray. Some questions. So collagen supplements, do they provide any role?
Hasn't really been studied in kids very much. Most of our collagen supplements have been studied more in the osteoarthritis population. When parents ask about things like collagen supplements or PRP injections for kids, I kind of remind them that a child is a walking sack of PRP and stem cells. And so not much information out there because we really haven't tested them in kids because we don't need it.
Okay, and so so if you do prolotherapy, do you do PRP or sugar water?
I do neither. I have used PRP a grand total of once, and that was in an 18-year-old.
Okay, and what injury was that?
I was an ACL tear.
ACL
Revision. Yeah.
And did it work?
I don't know. I just did it Monday.
That's good. All right. What about laser therapy?
You know, when it comes to a lot of those different modalities, you know, dry needling, tissue scraping, laser therapy, I kind of tell families, if it works for you, it works. I don't, there's no harm other than financial in doing any of those things. So I have no issues with it. The only time I would have an issue is if you're doing that in lieu of kind of the more traditional treatments.
Okay, and so there's some, I guess, well, I thought there was, you might have to inform me about this, but is there a controversy between inflammatories and anti-inflammatories? It seems like PRP, you're trying to create inflammation, and yet, you know, traditionally we always use anti-inflammatories.
A little bit, you know, like I said, that case on Monday, that was a revision ACL, and her first ACL, I am pretty sure failed because she got no inflammatory after her initial ACL. When I went in to revise it, there was like no blood supply, no synovialization of the structures that I had put in. So that's why I use PRP in that instance. But most of the time in kids, it is an inflammatory process that we're dealing with regards to the tendon insertions and the growth plates. So that's why anti-inflammatories are the more popular. Most of the time in kids, healing potential is so high, we don't have to tamp it down, or we don't have to increase it.
And in the case you were talking about, did you do the PRP intra-op?
Yes.
Okay, interesting. Okay. And then is part of this because the kid injuries in pediatrics, overuse injuries, is it because their bones are soft? Does that have anything to do with it?
Yeah. I mean, the modulus of elasticity, so the strength of bone in kids is different than adults. They're much less brittle. They are more elastic, but they're actually really strong. The problem is the growth plate. The growth plate is very, very weak relatively.
Okay. I think those were all my questions. There was a comment in the chat about thoughts on prolotherapy for Osgood-Schlatter, but that would be similar to what you answered earlier.
Yeah, I mean, prolotherapy is pretty controversial in the adult sports medicine world. It's used a lot of those like PRP, prolotherapy things are used more in the adult world, and there's very, very little research on those other modalities in the pediatric sports world. Again, our healing rates are just so good.
All right. All right. Thank you, Dr. Bray. Very interesting.
Okay.
All right. Thanks everyone for joining us today. And you will receive an email with a link for CME evaluation and credit. And we will not have updates in pediatrics in July, but we will return for another live stream in August. So thank you for joining us, everyone, and have a good week. Thanks, Dr. Bray.
You're welcome. Thank you.